Class, now I want to talk to you about some of the diagnostic studies that really can tell you a lot about your patient's renal health. And the first one is the urinalysis. And I've said before, you can really tell a lot about kidney function by a routine urinalysis. Every patient that gets admitted to the hospital will have this done. It's a request by the nurse or the admitting personnel to ask the patient for a sample. We really prefer a morning sample, but we'll settle for a sample any time of the day just to be able to get this lab result back as quickly as possible. I'm just going to go over some of the components and what is expected as a normal result and what could also provide evidence that your patient has some type of problem, either renal insufficiency, an infection, or maybe it's due to the fact that your patient's on a certain medication. So I'll just go over some of these, and I hope now that you'll be more conscious and aware of what your patient's urinalysis tells you about his or her renal health. Okay? First of all, under normal circumstances with a proper oral intake, the kidneys put out about 1,000 to 2,000 milliliters a day, okay, in various increments. And that obviously varies depending on how much we take in, exercise, activity, things like that. It's important to know, too, that 95% of the urine that's excreted is water, okay? And we look at the characteristics of the urine, and one thing we look at is color. And the normal appearance of color should be a light straw to a dark amber. And this is a very important feature of urine. It can really tell us a lot about the person's hydration status. Obviously, if you see very dark amber, very concentrated urine, that really signifies that the patient may be behind on a little bit of fluids. If you see that the urine is very pale, very diluted, almost looks like water, it could signify a very serious problem such as diabetes insipidus, or the fact that the patient is being overhydrated. But under normal circumstances, urine should be a light straw to a dark amber in color. Sometimes we see it maybe a smoky color, and that may be the result of blood in the urine. Could be from a woman's menses. It could be that the patient is having hematuria, which means blood in the urine. So anything that is a little obscure from the normal color of light straw to dark amber, it might be good to kind of investigate further as to why the patient's urine is that particular color. You also want to make sure that the urine is clear. If you took that specimen and held it up under a light, you should not be seeing any types of flecks or sediment in that urine. It should be nice and clear, and you should be able to see through to the other side of the container, okay? That's what normal urine should look like, free from any kind of contamination or even infection. Sometimes we see people with UTIs or urinary tract infections have more of a cloudy urine, pyuria. So that is something that you definitely want to further investigate. It could be evidence that the patient does have some kind of abscess, infection, something of that nature. As I said before, when we look at the color to either detect very dilute or very concentrated, that also correlates with what we call the specific gravity, okay? And the more pale the urine is, the lower the specific gravity would be. And the specific gravity of water is 1.00. So if you've got somebody who has a specific gravity of 1.006, you could pretty much assume that that urine is very dilute, and maybe the patient, is overhydrated. Maybe he's had a lot of alcohol to cause them to diurese a little more. And then, of course, for some serious situations like diabetes insipidus, or, sometimes we see patients who have received large doses of maybe IV diuretics such as furosemide will start to really put out a lot of urine, and the urine, as the patient continues to put it out, becomes a lot paler and paler. If color is very dark, I said before, really can signify dehydration. You might want to also check your patient's temperature, because sometimes fever will make a patient or a person become much more dehydrated much quicker. Red-brown could be myoglobin. We talked about that before. Could be due to diet or drugs. Orange, Pyridine. It's a drug we're going to talk about later on with UTIs. Very helpful when a person has a UTI and is starting to have spasms. The Pyridine, helps settle that all down and gives your patients a little bit of comfort. But unfortunately, it causes the urine to turn a very orange color, which can be very staining to the skin and also to someone's clothes or underwear. Blue or green could indicate Pseudomonas, or it could indicate that the patient's on some kind of medication like Elavil. Brown or black color could indicate melanin, bilirubin, maybe cascara, or even injectable iron. Sometimes the cloudier a urine is, it could have high levels of urinary protein. Cloudiness could also account for red blood cells, white blood cells, pus, things like that, due to some type of infection. Yellow foam can result from bilirubin, bile, severe cirrhosis. So these are just kind of different kinds of reasons why a patient may not have that perfect color of light straw to dark amber due to other pathologies, or even just to the fact that they're taking certain medications that actually turn the urine a different color. And that's why, as we do history and physicals on these patients, they might say, yeah, I noticed, when I urinated, oh my goodness, my urine was a certain color. And, they might be very alarmed by that, and that may be what, caused them to come to the physician's office. A lot of times when a person calls the doctor's office and kind of shares with them what their urine looks like, it might be a good idea to actually bring in a specimen for the physician or the nurse practitioner or the nurse to actually assess the color and determine what the reason for that kind of obscure color is. Odor, very important. Odor should be faintly ammonia, okay? It makes sense because you've got ammonium as a byproduct of protein breakdown and things like that. So that is normal to have that scent come from one's urine. Might be a little bit more concentrated, a little bit more robust. Sometimes when a patient is a little bit more dehydrated and the urine is a little bit more concentrated. But for the most part, That is the aroma that's usually associated with urine is a faint ammonia type smell. Okay, so don't be alarmed, and it'll make more sense to you when you now are aware of this. But things that are not normal are foul or unpleasant odors, and that will determine if the patient does have a urinary tract infection. What is the causative organism that's causing the infection will determine what kind of pungency or nasty smell you may be able to kind of sniff from that particular organism. Remember, your patients with diabetic ketoacidosis may actually have urine that's sweet and fruity. Sometimes certain foods give off an aroma. Asparagus gives off kind of a strange, funny smell after one eats asparagus. As far as pH, it should run anywhere from 4.6 to 8. The average is about 6. Anytime it is below 4.5, it's more acidotic, and you might see this with patients who develop metabolic acidosis or respiratory acidosis. Might be more acidic with diets that are high in meat and proteins. The more alkalotic or alkaline the urine is, the higher risk to acquire a UTI. So that's why it's important to kind of assess what that pH of the urine is, because if someone eats a lot of fruits and vegetables, it tends to make urine a little bit more alkaline, which could put that person more at risk for developing a urinary tract infection. Specific gravity, I've somewhat talked about that. The norm is about 10.05 to 10.30. Obviously, when it becomes very low, below 10.05, patients are overhydrated. Urine will be very clear, almost watery-like, and could indicate DI or excessive diuresis from a medication. And with that, we would be very concerned because a patient could develop a very serious potassium deficit. Anything over 10.30, patients could be very dehydrated, have a serious fever, which will dehydrate them even faster. Could also have problems with vomiting and diarrhea, which is the cause of their dehydration. Could be due to the fact that they're not drinking much, or also the fact that maybe they've had contrast media, which that is the way it's excreted, so it's going to make the urine much more concentrated, okay? And also the presence of ADH will cause a person to have a much higher specific gravity. Protein, your book talks about 2 to 8 milligrams per deciliter, but anything over that is a serious situation. We call that microalbuminuria, and we've been talking a lot about that throughout the whole semester, or this whole summer, and could indicate there is proteinuria in the urine. Could be due to excessive exercise, fever, stress. I really don't think you should be seeing much protein in the urine. Sometimes you will with some of these situations, as I said before, but it only should be very, very small. Obviously, with increased protein in the urine could indicate kidney disease, some of the cancers like leukemia, multiple myeloma, even septicemia. So just kind of watch your patient and assess them thoroughly. Then you'll definitely look at BUN and creatinines, and even creatinine clearance that are done over a 24-hour period, and then looking at one's GFR to determine if there is any significant renal insufficiency. Glucose, there should be none to trace, because that would indicate your patient has reached renal threshold and that urine is being spilled over. I mean, that sugar is being, or glucose is being spilled over into the person's urine. Ketones, negative. If they are developing ketones, if they're diabetic, we know that moderate to high would indicate a poor glucose control and maybe need some adjustments in their medication, diet, and you know, those kinds of things. And we've talked about that extensively in our diabetes lecture. You might see people that go on these starvation diets have a little bit of ketones in their urine also, just because of the breakdown of those fatty acids, because they're trying to find some kind of source of energy. When people do not eat the right nutrients and go on these starvation diets, they become very ketotic, and that is what we see very often, is the breakdown of those fatty acids that are seen through the ketones that are present in the person's urine. Obviously, red blood cells and white blood cells should not be present. If they are, it probably indicates they have some kind of urinary tract infection. Okay. Castor rare, another indication that the patient may have a urinary tract infection, maybe kidney disease, or even fever. It's also important to know too that CAST also indicate the presence of bacteria, protein, as with renal disease, and sometimes we see CAST with urinary calculi or kidney stones. When we see this kind of these particles or whatever characteristics found in the urine, then it's probably a good time to do a CNS of the urine to determine specifically if there is a organism causing a urinary tract infection. We want to know which organism it is so we can treat appropriately with the correct antibiotic. Sometimes parasites are seen. Trichomonas vaginalis indicates infection. Prostate, vaginal, urethral infections. Leucoesterose is a evidence of infection. It's an enzyme byproduct of white blood cells. Nitrites, E. coli also indicate infection. So those are some of the important findings that you would kind of want to assess for in your patient's routine urinalysis to determine if there's any kind of impending infection, renal insufficiency, signs of dehydration, evidence of a certain kind of medication that's giving the patient a certain color or characteristic that normally should not be present, only due to the fact that the patient is taking that kind of a medicine. So I hope that helps you to better understand what should be there and what should not be in one's urinalysis, and hopefully your doctor's aware of it, okay? Because we just want to make sure that the physicians are definitely accurately assessing these things, because they may want to order further testing if they're a little bit concerned about certain things that are showing up in the patient's routine urinalysis. So now what we're going to do is talk about significant blood work related to kidney function. And some of these, as I said before, are not unfamiliar to you. You've probably been assessing these particular lab values, which you should be, because it really tells us about our patient's kidney function. Okay. First of all, serum creatinine, which is no stranger to any of us. that's used to diagnose kidney dysfunction. Remember, creatinine is a byproduct of the breakdown of muscle and is excreted by the kidneys. And what I find is very interesting that about 50% or more of nephrons are destroyed, where you would actually start to see serum creatinine levels start to rise. So half of those million nephrons that are in the kidneys have to be destroyed, where you start to see an increase in your patient's serum creatinine levels. So that's a lot of destruction. And then you want to think about what is it that's destroying those nephrons to cause that serum creatinine to rise, because, man, must be something very powerful to be able to destroy that many nephrons, which probably is a process that has occurred over a fair amount of time. There's also a normal BUN and creatinine ratio, which is about a 10-to-1, and values are not affected by hydration status. And that usually is the normal creatinine levels are about 0.5 to 1.5 deciliters per hour. Deciliters per liter, sorry. So that's your serum creatinine. And really, the important thing that should be taken from creatinine levels is what is on this screen. Produced when protein or muscle breaks down, and no common pathological other than renal disease increases serum creatinine. Levels should be about 0.5 to 1.2. The other one that I was reading happened to be, what we see with the BUN and creatinine ratio. So this is what we're going to probably assess when we're going to see that certain diagnostics with contrast are ordered for our patients, because the first thing we're going to look at is the integrity of the kidneys to determine if this is a good idea to give them a dye, because let's face it, a dye, a contrast media, is a nephrotoxic agent. So we want to make sure if our patient can tolerate this, and the kidneys of that patient can tolerate it also. BUN is blood urea nitrogen. It measures the renal excretion of urea nitrogen, a byproduct of protein breakdown in the liver. Normal is about 10 to 20. Other reasons it can be up rather than renal disease is the fact that your patient may have be hydrated, because this one will assess hydration status. Other reasons could be high protein diet, hepatic disease, or even someone who's had a GI bleed. Sometimes you also see it elevated after a person gets a blood transfusion. I've seen that in my prior experiences. The reason it might be down is because malnutrition, or fluid volume excess, or again severe hepatic damage. Liver must function properly to produce urea nitrogen. So when liver and kidney dysfunctions are present, urea nitrogen levels are actually decreased because the liver function limits urea production. And of course, unlike serum creatinine, your BUN is not always increased due to kidney disease. Okay, these are other increased levels. Other reasons for increased levels: rapid cell destruction from infection, cancer treatment, steroid therapy, and injured tissue. Breakdown of that muscle or tissue causing the BUN levels to rise. BUN to serum creatinine ratios can help determine whether non-kidney related factors such as decreased cardiac output or red blood cell destruction are causing increased BUN levels. When your blood volume is deficient, such as in dehydration, or cardiac output is low, the BUN level rises more rapidly than a serum creatinine. As a result, this ratio of BUN to creatinine is also elevated. However, the elevated serum creatinine and BUN suggests kidney dysfunction. Another thing that's not on this PowerPoint slide is blood osmolarity. And we've talked about this quite a lot in regards to hormones, particularly ADH. It is a measure of overall concentration of particles in the blood, and it's a good indicator of hydration status. The normal is anywhere from 285 or 285 to 294, 285 to 295, and blood osmolarity will decrease, so the release of ADH is inhibited. And without ADH, the distal tubules and collecting ducts are not permeable to water, so as a result, water is excreted, not reabsorbed, so that will cause blood osmolarity to increase. So when blood osmolarity is increased, which indicates that the patient is dehydrated, ADH is released, and that means that water will be reabsorbed and blood osmolarity will start to come down. So, these are other things that should not or should be in your urine, okay? And I already went over those. Microalbuminuria, glucoesterase, it's an enzyme found in some white blood cells, and that could indicate a UTI. Nitrates also, sediment, things like that. Another thing that's really important that I didn't put on the PowerPoint slide is a creatinine clearance. It calculates the measure of GFR, glomerular filtration rate, and it's the best indicator overall of kidney function based on a 24-hour period. Compares blood with urine, okay? Patient's age, gender, height, weight, diet, and activity level influence the expected amount of creatinine to be excreted. And these factors are considered when interpreting these creatinine clearance results. So you're going to have different normal ranges for men versus women. And creatinine clearance really helps to determine the patient's current kidney function, and a decrease in creatinine clearance may require reducing drug doses and often signifies why there is a kidney deterioration. All right. A little bit about urine electrolytes. Obviously, sodium is one of them. It's the amount of sodium excreted is nearly equal to the amount taken in. Okay. And sometimes when we see sodium problems with the kidneys, if it's less than 10 milliequivalents per liter, it indicates that the tubules are able to conserve sodium. And there's also urine osmolarity that they can do. It measures the concentration of particles in a solution, okay? And we think of those particles as electrolytes, glucose, urea, and creatinine. And this value can vary anywhere from 50 to 1400 milliosmoles per liter, depending on hydration and kidney function. With average fluid intake, the range for urine osmolarity is about 300 to 900. And certain solutes, such as electrolytes, acids, and other waste of normal metabolism, are continually produced and secreted on a regular basis. And that refers to the obligatory solute excretion. Okay. So, those are things that I just wanted to make sure I went over with you. And this last thing is about specimens, okay? Many times the physician may order 24-hour urine collections for creatinine, BUN, sodium, for chloride, calcium, maybe for catecholamines. Whatever the case may be, your responsibility is to know exactly what the prep is. Can the patient eat? Is he supposed to be NPO? Are there certain limitations to the things that he can eat? So that we don't have to keep putting the patient through these diagnostics, that they get them done right away. And that's as long as the prep was adhered to, and we do exactly what the patient needs to do in order to give us a reliable and legitimate result back from these tests. And they'll indicate exactly what the interpretation of those test results would mean. What we do very often is we see patients do voided urines where they collect the first specimen in the morning because it's more concentrated. The important thing is to get them to the lab as soon as possible. You don't want them sitting on the unit shelves very long because urine starts to deteriorate. The urine also becomes much more alkaline, which increases cell breakdown. So obviously the testing will be very unreliable and will not really be very beneficial, but unfortunately the patient, if any part or type of the test is done, the patient will still be charged. You might want to do a clean catch, which we'll explain that to the patient, and they clean before voiding, and know how much urine is needed for these specimens to be carried out. This one only requires 1 ounce. It's needed, which is about 30 milliliters. So it's important to make sure that we get the correct amount so that they can run the test on that particular urine sample. Sometimes we might have to obtain, as I said before, there may be times where we need to get a specimen while our patients have catheters. So make sure that you follow hospital policy by cleaning the port properly and making sure that you get enough of the specimen to be able to run the test correctly. Sometimes these specimens need to be stored on ice, free of fecal contaminants, menstrual blood, or even tissues. So make sure if a special test is ordered for these patients and maybe the woman is on her menses, we might have to delay the test because it's only going to contaminate the specimen and won't be good anyway, so we don't want to put them through that financial burden or stress, along with making sure that they collect every bit of urine in a 24-hour period. And that's what's important too, is some of these are 24-hour specimens, and be sure that you explain the procedure to the patient, that your patient doesn't accidentally urinate in the toilet and doesn't unfortunately save that specimen. Then guess what? You'll have to start from the beginning, and in order to get the proper results. So it's just our responsibility to make sure that we understand what's the prep, what do we have to continue to do for the patient while the test is in progress, and are there any additives, and if there are, make sure that they don't cause any harm to the patient, to their eyes or anything like that. If lab has to add certain additives like acid or anything like that. So just make sure we follow proper hospital procedure. If you're not sure, call the lab and they'll be happy to tell you exactly what your responsibility as a nurse is to make sure that we get the sample correctly and that we can get very, very reliable results. And it's also a good idea to kind of figure out, why is the patient having this particular test ordered. Kind of gives you a little bit more information about where the physician's going with this to be able to diagnose your patient if you see that they're having some kind of very strange manifestation that we really don't know what's causing it. Okay, so again, this is just a review of the abnormalities seen in a routine urinalysis. What colorless or pale means, what red-brown means, what hazy or cloudy mean, what the actual odor should be. It should be a slight ammonia. Foul or putrid, that could indicate bacteria, and of course sweet and fruity could be ketoacidosis. And again, remember to assess daily amount. If we see that our patient's urinary output is really starting to dwindle, less than 500 milliliters a day, with an adequate intake, this could really begin alerting you to that something is very seriously wrong. That's why some of these patients should all be on strict INO for 24 hours or 8 hours, because we really need to know what the patients are taking in or taking out or putting out. And the thing is, though, this is just so hard to carry out to its best potential, because so many of the ancillary help, and as well as the nurses too, forget to mark down things off their tray or from any other extra fluids that the patient may be getting, from somebody on the floor. He calls, the patient rings his call bell. He says, yeah, I want a coffee. Well, maybe that was not computed into their daily intake in the last 24 hours. So there's a lot of human error when it comes to intake and output. That's why we back that up with the ability to just go ahead and weigh these patients every day, and of course to assess any visible peripheral edema, and of course to auscultate their lungs. Again, just another review of the routine urinalysis.